So, importance of IVUS in proper balloon and stent sizing in below-the-knee intervention, case presentation from the Midwest Cardiovascular Research Foundation. Again, Dr. Shammas is the primary operator. Just to start with, I have no disclosures. Angiography is suboptimal when it comes to estimating vessel size, plaque morphology, calcium burden, and thrombus burden. And there are many studies on that, comparing it to IVUS as well. So in this case, we utilized IVUS in below-the-knee intervention. In a case of CLI, we also had to use a retrograde approach with a dual axis. So starting with the case, a 78-year-old gentleman has diabetes, coronary artery disease, peripheral artery disease, has a non-healing ulcer over his left heel. He was brought in for intervention for a CLI case. I think I can repeat the images here. So you can appreciate the patient had a stent over his distal SFA. There is an end-stent restenosis. Vessel reconstitutes distally. There is a single runoff, which is the 80. Peroneal almost is cut in the middle here. Really severe, almost a CTO of his distal SFA. So we decided to proceed with a antegrade approach from the contralateral common femoral, right common femoral axis. Unfortunately, despite multiple wire escalation, we were unsuccessful with crossing from an antegrade approach. Despite the patient having only a single runoff, which is actually diseased with CTO at the proximal AT, we decided with ultrasound guided, we'll get a 4 French sheath. Of course, the IV nitro, IV heparin was given to the patient. And the images here on the left, you can barely see a wire from an antegrade approach. The wire is somewhere, but we were unsuccessful. The next image in the middle is a successful intraluminal wire from a dorsalis pedis axis. And the last image shows the wire crossing almost to the distal P3 segment. So now we applied IVUS from retrograde. So we did some measurements on the IVUS here. The orange and the yellow are internal elastic to internal elastic estimates of the diameter. Surprisingly, this was around 4 millimeter. The best estimate of the diameter from angiogram was around 2.8 millimeters. External to external elastic, the purple and red showed a 6 millimeter measurements. And this is at the proximal AT. So we did high pressure dilation. We also appreciate here a calcified fibrotic medial ring, which also explains the nature of the disease in below-the-knee peripheral artery disease. We had to dilate up to 16 atmosphere, and we noticed here in the image that there is this break in this ring with this high pressure of dilation, which resulted in a dissection. This dissection was not noted on angiogram. So we do have an eye dissection classification, which was suggested by, proposed by Dr. Shammas, and it's published. So based on that classification, this would be a C2 classification. So just going fast through this eye dissection grading system, it depends on 2 criteria. The depth of the dissection, you will get a letter A, B, and C. A if it's in the intima, B for the media, and C for the adventitia. And the second stage would be depending on the arc of dissection. If it's less than 180 in circumference, it will be a grade 1. Grade 2 if it's more than 180. So just a question to the audience, what do you guys think? There's a media here highlighted by purple with the arc here. What would be the grade for this based on the eye dissection? So this will be a B1 because it's less than 180. So just going through those classification system from A1 to C2, don't confuse this with the NHLBI classification, which is an angio-based from A to F. The A here does not correlate with the A in the NHLBI angio-based classification. Proceeding with the case, so we then did a dilation with a regular balloon to the distal SFA using a 6 by 120 balloon. Unfortunately, we noted a type C dissection over the distal popliteal almost here. Given that the patient has a single runoff, we proceeded to not compromise his only runoff. We stented using a coronary DES stents sized up to 4 millimeter in diameter based on what we saw from the IVUS. We used 2 stents in a tandem fashion, 4 by 38 and 4 by 33 Zions DES from a retrograde approach. And the second image here highlights those stents. The last image, we had Illuvia, which is a drug-eluting stent over the distal FemPop region placed as well. We did use DCB to the areas that were not stented. Finally, we pulled the pedal axis sheet. Of course, we held pressure manually up to 10 minutes. And of course, we had checked what the ACT was prior to that. And we did this final angio from an antegrade approach. Vessel is patent, and the integrity of the vessel is kept. As you can see, there is no distal embolization. So what is highlighted in this case? First, angiography underestimates the size of the infrapopliteal vessels. IVUS guided approach was helpful in this case in a patient with CLI for proper balloon and stent sizing. Also, dissections are missed on angiography, which can be detected on IVUS, and that's helpful. High pressure inflations are needed when you dilate and treat below the knee vessels, as we appreciated the severe ring of calcinosis at the proximal ET. Finally, pedal axis is to be used in critical limb ischemia, even if the patient has a single runoff. It was the only last resort in this case. So we do hypothesize that undersizing of the balloons and stent in the prior trials might be the reason for failure in below-the-knee studies. So we have an ongoing study at the foundation, which is the eye dissection below the knee feasibility single-arm study, which at this point is just the use of IVUS in below-the-knee intervention. We have two arms. We either use a PTA or a atherectomy. We do have preliminary results to be presented in coming conferences. Thank you.
So when you did the initial IVUS and you saw that the vessel was 4 millimeters distally and 6 millimeters at the kind of near the TP trunk, I mean, were you comfortable placing a 6 millimeter balloon in these locations? I mean, one thing is visually it looks like it's no more than 3, and then here you have an IVUS that's saying it's 6. What's your actual treatment strategy? How do you make your choices there?
So the actual 4 millimeter was after dilation with a small balloon. We started, I believe, with a 2 millimeter coronary balloon, and this image was after the dilation.
I got it.
Yeah.
So do you always utilize IVUS in below-the-knee vessels, or is it on a case-by-case basis?
Of course, yeah. At this point, it's a case-by-case basis, and I mean, for the patients who would consent for the study, we would use the IVUS, of course. Yeah, it's not a standard of care. No.
Thank you for a nice, great presentation. I'm Amane Kosugi from Japan. And I totally agree with your strategy that in the below-the-knee intervention, IVUS can upgrade the size of the balloon. I have one question about the eye dissection classification. How can you use that classification for the strategy? Implanting stent or leave it alone? What is the cutoff point of your strategy?
So what's the outcomes from every classification you're asking?
So no, eye dissection.
At one point in the classification, you think it should be treated versus left alone?
Yeah,
sure. Excellent question. Yeah. So it's at this point, I don't think we have really outcomes, but it's still on the operators.
How about your opinion?
Yeah, definitely. I mean, maybe an A2 dissection where the circumference is more than 180 U, and depends on the severity of the case, you would opt to maybe use a stent there. Maybe.
How about the depth of the dissection? Does it
yes.
care?
I mean, I would refer this question to
Dr. Shammas, since you came up with this, can you tell us about it a little bit more?
Yeah, this is an excellent question.
Educate us.
You know, a couple of things. You know, when we did the dissection classification was based on two things. Pathologic data from the Mount Sinai guys that showed if you go deep into the media and the adventitia, you have much higher likelihood of restenosis and problems. The second one is a lot actually of the data that came from Japan showing a lot of the arc, of over 180 degree, can potentially create problems. So we create a hybrid classification that used the pathologic analysis with a lot of the data that came from our Japanese colleagues and essentially created this dissection. So to answer your question, even though we don't have direct data that tells us which IVUS-based image will allow us to do like a TAC or a stent or whatever, we still believe anything over 180 degree is more likely to create a problem, and anything that goes into the media and the adventitia needs to be repaired. So this is kind of what we're using. We still don't have all the data, but we hope to have some data to support that concept in the near future.
Thank you.
Yeah.
All right, we'll move
Thanks.
on. Thank you.